Welcome. We've been waiting for you.
Well, you can start.
Hi there. Welcome. I'm George. I'm your facilitator for today's meeting, and we got a really good subject. We got a good crew here, and we want to thank SBP for this facility. It's got another facility for you men in the back down the hall there, and for women also, but you men have a more urgent need, at least some of you do. And so we got a wonderful day, and we have a great speaker. And because some of you have short-term memory loss, like me, I may repeat myself with these slides. These are for your newcomers. Some of your old timers, I see your lips move when I go through this list here. Okay, here we go. These are the volunteers that make this thing work. You know, if you want to have fun with prostate cancer, become a volunteer. Us guys have fun, don't we? Yay! The pay is lousy, but the benefit program is a real joy for us to be able to be here to help you. And I don't need to go down the list, but almost all of us are here, and as I mentioned, we enjoy being a volunteer. And if you want to come and help us, because we're kind of getting on in years, and so we need some young blood in here to help us out, and we'll show how to do it. Okay, the newcomer package. Did every newcomer get the package from Jim? Anybody not get it? Okay, appreciate you filling out the cover sheet. Okay, we got it back here. Because the purpose of that front cover is to help us measure your interest and needs. And also, Jean will give you a call during the week and see if you have any questions, what we might be able to do to help you. And what's the purpose? We're here to support you. We're not a replacement for your medical professional. What we talk about is basically from a patient's perspective. So what you hear here, we hope will help you manage your own case. You have to manage your own case. Your doctor has 3,000 or more patients, and you have to be the one. You know your own quality of life issues. You know what upsets you and what bothers you and so forth. So that's what we're trying to do. Hopefully what we're doing here is raising questions that you want to go to your doctor and ask about. What about this? How come that? And so forth. So now when you hear our great speaker, you don't have to take notes because it'll be on a DVD next month, including the graphics. So for $10, you're going to get a jewel of some information. So relax and listen. But again, we're no substitute for your doctor. Okay, what do we do for you? We have a wonderful website. And John, where are you? Where's our webmaster? Where'd he go? Okay, he's around here. Okay, and then we got the library, and Bill Bailey, where are you, Bill? He's out front. Okay, we got some wonderful DVDs from previous speakers and from conferences and so forth, and we have some stuff that you can get for free out on the table. Other stuff you can borrow for a month and bring them back. And then we have some great books, some top books, the top bestsellers that will help you. The whole profession is improving greatly, so the new books are important. Newsletter. Where's our editor sitting? There he is. There's Jim. And then we have Bill. Raise your hand, Bill. He's the one that gives a summary of the talk. Does a super job on that, but no graphics. So if you want the graphics, get the DVD. Okay, outreach. We're always looking for new members because they're going to be in need because of the complexity of this disease. This is a complex disease, as you're probably aware. There's 16 different types of treatments. There's 28 FDA-approved drugs. and which ones are best for you. And we hope we help clarify some of that. But we dependent upon you to talk to friends. Your buddies are the same age as you are, and they may be facing prostate cancer, or they certainly should be getting a PSA. If you have sons, their likelihood of having prostate cancer is higher than the average. So you remind your sons about getting a PSA, and of course, if they do have it, come on out and join our meetings. Okay, we're going to do our monthly survey. Please raise your hand in response. How many are here for the first time? Look at those. Good. Welcome. Welcome. Keep coming back. If you newcomers have any questions at the end of this meeting that's not related to the subject of our speaker, I'll be down front and try to guide you or help tell you where maybe things could be clarified for you. How many have been recently diagnosed with prostate cancer? It may still be a puzzle to you, and that's why we're here. How many have had prostate cancer for just up to a year? Raise your hand. Okay, not that many, but all right. Up to 4 years, raise your hand. Let's see if we got a bell-shaped curve here, all right. 5 to 10 years, yeah, all right. 11 to 15 years, look at that for you newcomers. And above 15 years, raise your hand. See, I got 21. Anybody got me beat?
26.
26, and he's smiling. He's also on intermittent treatment too.
Still on intermittent hormone blockade, yes.
Yeah, okay, so good for you.
What is that?
Okay, you can ask him after the meeting.
Okay.
All right, that's where you go on the drugs for a while and then you don't. See, and that's maybe something you'd like to touch on. And okay, and is Jack here? There he is. How many?
28.
28. Look at that, and he's smiling too. And so says, okay, let's move on here. Treatment survey. All right. How many have not had treatment but are on active surveillance? Raise your hand. Because of the subject matter, those people, the majority, don't need to come. Sorry about that. And now on surgery of all kinds on your prostate. Okay, that has been the standard. Now let's see what happens when we go radiation. Raise your hand for radiation. A few more on radiation now. That's a growing trend. And ADT, also known as hormone therapy. There you are. There you are. Me too. Gene has been raising his hand constantly here because he's done all of these. So if you want to know which one he really enjoyed the most, ask him. Okay, chemotherapy. How many are on chemotherapy? Well, we got a few here. Well, yeah, we have a few. New treatments. Just freeze it, microwave it, or whatever. How many are new treatments? Okay. Okay, let me ask you, what's your treatment, new treatment?
Zytiga, Keytruda, lutetium, amongst others.
Okay, and you got those plus what else?
No, I don't have all of those. I've got Zolfigo, Provenge, Keytruda, and that's for now.
Okay. Who else raised their hand? Okay. Zytiga. Okay. Okay. And where do you get that done?
UCLA.
Okay. All right. Some go to Australia. Okay. Back there? Okay. Right. Right. Anybody on Erlita? I am. That's a new one, just out a year ago. All right, recurrence. How many have had recurrence? A number of you have. I have too. How many are undecided what to do next? Yeah, and maybe we'll hear something, but remember, ask your doctor. Okay, another little special questionnaire. How many have castration-resistant prostate cancer? Raise your hand. Now, do you know what it is? Okay, that's when you're taking, make it simple, Lupron, and it stops working. You're becoming castration-resistant. Let's see your hand again. Okay. Next question, how many have metastatic prostate cancer? Raise your hand. Well, they tend to go together, but that's how many we have. Now, how many have non-metastatic CRPC? Raise your hand. I'm alone. See, mine is growing. It's growing real fast. It tripled last month, my PSA. But it has not metastasized. It has not gone in a remote area. So I'm no longer interested in your subject. No, I am, because guess what? It may metastasize too, see? So I'm the unusual one. Of those 28, I only qualify for 2, Erlita and now Zytiga. All these others, you have to have metastasized cancer. Mine is down in the pelvic region, hasn't gone to a remote area. See? So that's kind of a rarity. Maybe it's good news, but I'm looking forward to hearing about today. But there's a lot of you folks that have metastasized. Okay, here we go. We need your support to be able to have this function here. And so this is where we're going to ask for money. And the baskets, what did we do with the basket? Did we?
Hats.
Hat. Oh, okay. All right. Bill, will you get a hat here and pass the hat? All right, well, we're passing the hat. Let me give you the 6 principles that guide us in case management. 1, get early detection. Get an early PSA. If you're over 50, get one. Wait if you want too late detection. This disease doesn't have any really good advanced signals. By the time it's bleeding and in pain, it may be too late. Get a high definition, an MRI of your prostate. So then it can be targeted, where they can take that core and go right to the lesion or tumor. And they'll probably want to do the traditional random 12 under those guidelines. Know your Gleason score, track it. Because that's a key whether you qualify for active surveillance and not invasive treatment. And then once that is not going to work for you, what kind of treatment should you have? As I mentioned, there's 16. And some are not maybe make you feel good, some are better. So we're going to learn about some of those treatments now.
Question?
Yes?
Why is genomic testing not on that list?
Pardon?
Why is genomic testing not on that list?
Because it's not a treatment. Okay. You want me to ask that?
About diagnostics.
Okay. Good point. You're going to be talking about that? Okay. All right. We're going to withhold the questions for our speaker until the end, and then I'll be pointing at you. We're going to sweep the audience, so you'll get your chance. So Gene has a few words.
Yeah. Just one quick note for those that have not already decided to participate. There's brochures out on the freebie table of the upcoming midterm Prostate Cancer Research Institute conference coming up on the 30th of March. And as usual, several highly qualified doctors with the most recently updated information. So pick up the brochures if you want. Now, to be unusual, as I usually am, I'm not going to introduce the speaker because the gentleman asked me if he could do that for me. So Aaron Lamb, please come up.
Thanks, Gene. So Dr. McKay is one of the best doctors who's ever treated me. When I walked into her office a year and a half ago, I was 70 years old and bald. And look at me now. Okay, I wasn't literally, but figuratively I was. I had just been diagnosed with stage 4 after my operation, and I was, dealing with a cancer that I didn't think I'd have to deal with for another 30 years. She and her staff were on top of my treatment from day one, ordering the latest genetic tests and MRIs, dealing with my insurance company, dealing with gaps left in my recovery treatment from my surgeon. She had multiple strategies that she was considering and expecting that I would be cured and live. And she told me she expects to see me at least living into my 70s. She's had a lot of patience dealing with my neuroses as I started ADT and Zytiga, connected me with other wonderful doctors to ensure success. And I feel lucky and honored. And from others I saw greeting her this morning, I think I'm not the only person in the room. But yeah, I feel honored to introduce Dr. McKay.
Thank you, Aaron.
So, Dr. Rana McKay is a board-certified medical oncologist who specializes in treating people with urologic cancers, including bladder, kidney, prostate, and testicular cancers. Her primary research interests include the design and implementation of clinical trials to advance the treatment of patients with genitourinary cancers. Her work has appeared in peer-reviewed publications such as the Journal of Clinical Oncology, Clinical Cancer Research, and Cancer. She joined Moore's Cancer Center in 2016, but before that was a medical oncologist at Dana-Farber, Brigham, and Women's Cancer Center in Boston. She completed a fellowship in oncology and hematology at Dana-Farber Cancer Institute, completed a residency at Johns Hopkins, and received her medical degree from the University of Florida in Gainesville. She's a board-certified internal medicine and medical oncology. So thank you for joining us today.
Thank you so much.
Dr.
That's
McKay.
such a wonderful introduction.
Thank you.
Such an honor taking care of you and walking the path with you. Switching things a little bit to not just focus on metastatic prostate cancer, but rather high-risk disease, and also talking a little bit more about some novel trials and genomics, because I think a lot of patients have questions about genomics, what it all means, does it apply to me? So hopefully we'll begin to touch on that a little bit during this discussion. These are my disclosures. So we'll go through a little bit of background. We'll talk about tumor genetic testing, inherited genetic testing, and contributing to the prostate cancer fight. And we'll start by going through the background. So many people have prostate cancer. Prostate cancer is the most common cancer in men. Obviously, you all in this room are dealing with the consequences of this disease. Top leading cause of cancer in men, second leading cause of cancer death in the US in men. So this is a real problem for patients and for the medical community. And the incidence of prostate cancer, fortunately, it's been, it peaked up there. This is with the advent of PSA testing. We see a big peak in the incidence, but that kind of normalized, and now the incidence is declining. And this declining incidence here is probably related to a lot of messaging to the primary care community actually against PSA screening. So we're seeing kind of these fluctuations in the incidence. With regards to mortality of prostate cancer, this is it right here, it's certainly been declining, and that's related to earlier detection and better treatments. So just a little bit about how we treat prostate cancer, and obviously I'm gonna focus on the systemic therapy side of things, as I'm a medical oncologist, and you guys probably already know this, but the backbone of therapy for prostate cancer is really androgen deprivation therapy, and that understanding that, background biology really was discovered in the 1940s. And it's been the backbone of therapy since the 1940s. This is the landmark publication from Huggins and Hodges, basically where they had, they initially conducted their studies in dogs, and then actually conducted studies in patients and found that actually castrating individuals actually dropped their PSAs down and treated prostate cancer. And actually for this discovery back in the 1940s, it won the Nobel Prize in medicine. And really, here's more on that, this is back in 1941, in this paper, evidence is presented that significant improvement often occurs in the clinical condition of patients with far advanced cancer of the prostate after they have been subject to castration. Now, 75 years later, there's been a lot of changes to that treatment paradigm, but ADT remains the backbone of systemic therapy for this disease. And, there are different stages, different disease states of prostate cancer. And I love that question answer of the hand raising, where we kind of got a sense of the different stages of the disease that you all are going through, from just being newly diagnosed, maybe with localized disease, getting surgery, radiation. Then subsequent to that, if somebody has a recurrence, maybe their PSA is rising and they don't have metastases. And then, treating with hormonal therapy. And then in some situations, people get resistant to the hormone therapy, but they don't have mets like George, and they can get apalutamide or Erleada or enzalutamide. Or then, metastases develops, and, thinking about initially castration sensitive versus going into that castration resistant state, where there are these other more novel, newer therapies. So what's this concept of precision medicine? What's the power of precision medicine? So right now, when we look at the schema back here, outside of sort of the state of somebody's cancer, nothing really tells us if you have X, you should get Y. If your cancer is like this, you really need this drug. If this is the genetic makeup of your cancer, this is what you should get. And so we're really in a new era now of precision medicine, where we are trying to really understand what are the molecular drivers of each person's individual tumor, as opposed to just prostate cancer as a whole, but rather what is the genetic makeup of patient X versus patient Y versus patient Z, and can you specifically target that person's mutation? So that way each person is getting the right therapy, you're putting the right therapy in the right patient at the right time, you're not exposing people to therapies that may not work, and the toxicities of that. So this is the concept of precision medicine, instead of a one-size-kind-of-fits-all, trying to really understand the genomics of the disease. And we're right in the middle of this kind of era. We haven't really quite figured it out, but we're in the process of discovering what the right path is. So I wanted to talk to you a little bit about types of genetic testing. So you guys have probably heard about genetic testing and different options out there. Some of the terms that are used are next generation sequencing. And that's really to highlight the fact that, going back to the early 1990s, when we decoded the human genome for the first time, it was like a 10-year effort to do that. And now we can decode each individual's genome in a matter of a couple of days to weeks. And the costs of genomic testing have come down. So this is this next generation sequencing, as opposed to old generation sequencing. And there's two different types of sequencing. There's sequencing of the tumor itself. That's called somatic, so the actual tumor itself. And there's different types of genomic sequencing. It could be whole genome, meaning you sequence the entire DNA of the tumor. Or you could just sequence the exome, which is just the parts of the DNA that actually end up being coded into protein and RNA. There's panel testing, where you're just sequencing 300 or 500 genes. And this is typically done on tissue or blood. So that's really focused on the tumor. The somatic piece is focused on, well, what is the genetic makeup of the tumor? Because the genetic makeup of the tumor is different than the genetic makeup of you, because it's a tumor. Germline is actually testing, well, what is your genetic makeup? What is the genetic makeup of the normal cells inside your body? What are the genetic makeup of the cells you were born with? So germline. Okay, that mom and dad gave you. You've got one copy from mom, one copy from dad. What is that genetic makeup? And usually that's either done with blood, and they just take your white blood cells from your blood and sequence them, or it's done from some saliva, where they take the mucosa from your cheek and sequence that. So it's testing normal non-cancer cells or DNA. So those are the two different types of genetic testing. I know we're going to save questions at the end. I had integrated them throughout the talk, but this is kind of now moving in a little bit to the tumor genetic testing, okay? So in March of 2018, actually, I think it was actually even earlier than that. You know, how do you actually get your tumor tested? What is access to tumor testing? So CMS, which is basically the, Medicare and Medicaid services with regards to coverage for testing of, genetic testing in patients, actually came out with a statement that says for people who have either recurrent, relapsed, refractory, metastatic, or advanced stage 3-4 cancer, they will cover the cost of a genetic test. Because I think this is one of the things that I think always comes up is this covered? Will my insurance cover it? For most people who are Medicare or Medicaid patients, it should be covered. Okay, so I put this up there for to highlight that this is something that is kind of evolving, and a question to sort of ask your physician, your oncologist. When can I get this testing done, and when's the right time to get this testing done? So talking a little bit about genomics of advanced prostate cancer. So there's been a lot of challenges with understanding the genetics of prostate cancer, and one of the real reasons for that is because prostate cancer metastasizes to the bone or tends to spread to the bone. But the bone can be pretty tricky to handle. It's tough, it's hard. When the pathologist has, usually they have to put the bone in acid to get rid of the bone so they can handle the tissue. That affects the DNA. So it's just been a real challenge with regards to being able to understand the genomics of this disease. But there was this very large effort across multiple institutions to actually sit down and try to figure this out. Through the Stand Up to Cancer and the Prostate Cancer Foundation, through key institutions across the US and the UK, actually tried to genomically characterize 150 men with metastatic prostate cancer to try to understand what is the genetic makeup of this disease, what are the mutations that come about from this disease. And this is sort of a landmark paper by Robinson and colleagues that was published in Cell in 2015 that we constantly refer to, kind of the initial results from this effort. Okay, and you can see the different types of tumors that were tested, and with regards to lymph node, liver, people who had biopsies of lymph node, bone, liver, and just soft tissue, most sites that were metastasized, you could actually get genomic DNA out and interpret. 90% here for lymph node, 100% for liver, 93% for soft tissue, but the bone, it's more challenging to work with. So 50% of the time 57% of the time we're actually able to get something from the bone that we were able to interpret and get data from. So this slide is really to highlight the genomic landscape of this disease. And what we can see, I know it's a lot of different colors, there's all these different pathways here. And these are the most common pathways up here. So androgen receptor, even in the context of metastatic resistant prostate cancer, is altered in 80% of cases. We see P53 and P10 also being altered in a substantial number of patients, up on the orders of about 50%. These ERG fusions are altered in 50%. But the big thing here is kind of these pathways. So the AR pathway, which can be targeted with AR-targeted therapies, the PI3 kinase pathway. These are all pathways that tell the tumor cell to grow, or they dysregulate how the tumor cell is actually supposed to kill itself, because it's not a normal cell. It should not be there. So these are kind of growth pathways, and these all tend to be upregulated in prostate cancer. And one of the biggest ones that actually was a surprise from all of these efforts was actually the DNA repair pathway. And I'll go into that a little bit more. So the DNA repair pathways that was actually found to be altered here just by looking at the mutations in about 22% of patients. So how the cell actually repairs its DNA was dysregulated in these prostate cancer cells. And so why is that actually important? Why is it important to know that? Because it could potentially increase the susceptibility to different kinds of drugs. There's this concept of synthetic lethality. And when a cancer cell can't repair its DNA or a certain part of its DNA, people can be susceptible to drugs like PARP inhibitors or carboplatin. So here's a normal cell. There are these two steps, you can call this step 1 and step 2 for how it repairs its DNA. When cells have a BRCA mutation or a mutation in their homologous recombination, they're really dependent on this pathway to actually repair their DNA. But if you come in with a PARP inhibitor, if you come in with a PARP inhibitor and this pathway is broken, And this pathway doesn't work because you've given somebody a drug to block that pathway. And the cell can't repair its DNA, it dies. So this is how knowing this can actually open up the door for treatment options. And so this is kind of a summary of different kinds of studies that have used PARP inhibitors in people who have, in people who have metastatic prostate cancer. And you could actually see in people who actually had DNA repair abnormalities, and I'll highlight this row here, this row here, this study, this row here, the response rates are high, in the 80 to 90%. So it's worthwhile doing the test, okay? Because it can inform what we do. And this is just one of, I'm just focusing here on one of those pathways. While other targets are not as common as within the DNA repair pathway, this is sort of the whole concept of precision medicine. We've sequenced your tumor, we found you have a DNA repair aberration, we've given you a drug that we know works in that cohort of patients, and then it does work, okay? So that's the whole concept of precision medicine. So one of the landmark studies was the 2-PARP study. It's a phase 2 study where people with metastatic disease who had received prior chemotherapy actually received olaparib, which is a certain PARP inhibitor. The primary endpoint of this study was, did the PSA go down or did the cancer shrink on scans? And what they saw was actually people who had a positive biomarker, meaning people who actually had a problem with the way that their cancer cells repair their DNA, actually did better with this drug, okay? And because of this, actually the FDA granted breakthrough designation for olaparib monotherapy for BRCA1, 2, and ATM mutated prostate cancers. And now this drug is in phase 3 testing, and there's other PARP inhibitors like it, like rucaparib in 2018 just got granted the same designation. So there's a handful of PARP inhibitors that are out there, but I just highlight this as a case study in precision medicine, what precision medicine can do, okay? So at UCSD, we just completed accrual to this study, had a study of the combination of cediranib with olaparib in men with metastatic prostate cancer, and this study just completed. And this study is now actively accruing, a study of radium-223 and olaparib in men with metastatic prostate cancer with bone mets, and this is actively accruing now. So these are olaparib-based studies that we have open at our institution. But here's a listing from the Prostate Cancer Foundation website of key targets in prostate cancer and drugs that are in trial or drugs that are in the pipeline. So we talked a little bit about the DNA repair pathway. So there are drugs in trials and drugs in the pipeline, but there are other pathways as well. For one of the big ones is immunotherapy for people who have MSI high tumors, and it's probably only about 1% of prostate cancers. Pembrolizumab or Keytruda is approved for those patients. And people with CDK12 alterations, immunotherapy is being tested in that population of patients. But it's worthwhile doing the test. It all starts with the test, okay? So then a little bit about inherited genetic testing. So again, this is not testing the tumor. This is testing you. What were you born with? What were you born with that got passed on to you that you can pass on to your children? So different kind of testing done in a different kind of way, okay? And this is just sort of highlighting a story about a mother who had a mother who was diagnosed with breast cancer, but then she acquired the BRCA1 gene from mom. And so what does she tell her daughters? And so this is, it impacts cancer screening, it affects cascade testing for family members, but it does also have the potential to affect your treatment. If you have a BRCA alteration, PARP inhibitors, platinum chemotherapies, and others. So right now, what we're learning is that germline DNA repair gene mutations have been found in patients who have prostate cancer. And there was this large study published in the New England Journal of 692 men with metastatic prostate cancer, unselected for age, unselected for family history, they got their germline DNA sequence, meaning what they were born with, they got sequenced. And what we found was actually 11% of those patients, which is a substantial number, like 1 in 10 people, actually had a germline DNA repair aberration. And it didn't matter what their family history or age was. So even though we do semi-select based on age and family history, it really should be done on anybody, not just people who are younger or people who have a family history. And the prevalence in the metastatic setting actually exceeds that for what's in the localized space. So for example, the prevalence for people with localized prostate cancer is 4.6%, actually having a germline alteration. And for patients without cancer, it's 2.7%. And that's compared to this 11.8%. And because of this, actually, the guidelines have been altered, and this is like super tiny text, but basically the panel recommends inquiring about family and personal history of cancer with referrals to genetic counseling if somebody is suspected of having a familial cancer syndrome. In addition, due to the high prevalence of germline mutations, the panel recommends consideration for germline testing for all men with metastatic and high or very high risk clinically localized prostate cancer. So this has just entered into the screening, the guidelines. So it's worthwhile to ask your doctor about that. Should I get tested? What are the implications of that? Okay. And then this is just a little summary of, different, because one of the biggest things about getting tested is it covered by insurance? How is it going to affect my care? This is just a little bit of a summary of from this Modern Healthcare publication about some different health plans and whether they do or don't coverage, what their stance is. Some companies have no policy. For example, Aetna, Anthem don't really have a policy on it. Whereas, for other, Medicare, the CMS decision has already come out about this, but kind of just to give you a summary of different health plans and whether they do or don't cover it. All right, so shifting gears now. So we talked about the genetics of prostate cancer and the genetics of metastatic prostate cancer, so how to contribute to the prostate cancer fight. So what do we really know about the genetics of prostate cancer? It's complex. There's numerous genetic events that probably lead to the development of prostate cancer. Which genetic events are relevant for indolent or aggressive disease are unknown. People with advanced disease have more complex genetics, but really not enough. And can patients drive the field forward? Okay. So I wanted to talk to you a little bit about two initiatives. One is the Ironman Registry. So has anyone heard about Ironman? Okay. So Ironman is, so we'll talk a little bit about this. So more than, as we know, 300,000 men, die from prostate cancer each year, and that's unacceptable. And new treatments and therapies are coming about, but we really don't understand what's the best way to deliver these therapies to result in the best outcomes for patients. So Ironman is a registry of men with advanced prostate cancer, and it collects information about a man's type of prostate cancer, their treatments, side effects that they may be experiencing. Collecting and researching this information will really enable us to better understand what causes prostate cancer, how to stop or slow it, and what's really the best treatment. And it's an international registry. We at UCSD are one of 26 US sites, but it's really being opened across the globe, South Africa, Australia, Brazil, Europe, with the intent to try to get data on 500 men with prostate cancer across 9 countries. And the strength of Ironman is really in its global partnerships, okay, and connection to patients, families, doctors. And the registry basically collects patient data, treatment information, and a blood sample. And surveys basically get sent to patients to really understand what you are going through as a patient, not what your doctor thinks you're going through. Because it's different when I tell a registry what a patient is going through versus in your own words, you describing what you're actually going through. Mm-hmm. Yeah. Okay.
Can we get, I've been recently diagnosed, and I like to get some of that information about it, what other people have done and stuff like that.
Uh-huh.
Can I access those, that study?
Yeah, you can. So it's I believe it's Ironman. So here's the information. If you're interested in learning more about the registry, and Jennifer Palomino is our clinical research coordinator. And I hope that we're connected to internet because I have this. Oh, maybe we're not.
No, you're not.
Okay,
You're not.
that's okay. I had this video for you guys about Ironman, but if you're interested in learning more about the registry, you can certainly contact us. It's for men with metastatic disease, advanced disease. Yeah, but we're more than happy to share that information with you. And then a little bit about the Metastatic Prostate Cancer Project, which I think you guys have previously heard about in this venue. And this is where we're actually partnering directly with patients to accelerate the understanding of metastatic prostate cancer. And so what are the challenges of studying patient tumor samples? So, out of all patients in the US with cancer, probably only about 5 to 10% of them ever participate in clinical trials, and we ever actually learn about their true experience. But and 85% of prostate cancer patients are actually treated in the community, not at an academic center. And so there's this gap with understanding of what patients actually are going through. And most patients are actually not readily, they never even touch base with academia for us to learn and understand more about their prostate cancer. But social media and other kinds of, platforms are actually enabling patients to directly partner with research initiatives that sort of almost like independently of their physician, mainly, not to say their physician, but independent of, they can do it at their own accord, on their own will. And that's what the Metastatic Prostate Cancer Project is, where you can sort of directly partner in research. This is a huge initiative that's been coordinated out of the Dana-Farber and the Broad, where there's a similar project in breast cancer and pancreatic cancer where patients can basically log in, register, set up an account, and report their real-time patient data. And the goal is to basically generate a publicly available database of clinical, genomic, and patient-reported data in metastatic prostate cancer. And this is how you participate. You basically register. There's a kit that if you want to do this, you can do this. There's a kit that gets sent to your house that you can either get a spit sample or a blood sample at any blood draw that you'd be undergoing, and then learn along the way. And this is sort of the kit that gets blood, saliva, or liquid biopsy. And right now, 650 men have joined, and there's this, definitely a big pull from the San Diego area here. So I think you guys have probably heard about this before. So the project is designed to pay it forward to the future clinical trial design, understanding new drug development, to share select generalizable information that is found, to share data with other organizations. But the project is not intended to give personal genetic data back to patients. It's sort of paying it forward. And numbers are everything. So that's a little bit about that project. So thank you for those of you who have signed up already. Just kind of take home message. So novel treatment strategies are evolving for men with high risk and advanced prostate cancer. Genomic profiling of tumor tissue and normal tissue has the potential to inform prognosis and potentially treatment of patients with advanced disease. Certainly encourage clinical trial participation, really geared at trying to improve the survival for men with prostate cancer. This is, our contact information, my contact information. Lauren Stewart's my administrative assistant. Her phone number is there. If you're interested in learning about trials, that link right there, the clinical trial portfolio. If you're interested in learning about prostate cancer, there's more data on UCSD's website and also Prostate Cancer Foundation, which is a huge supporter. And then this is sort of the team at the Farber, UCSD, Yale, Sloan Kettering that's helped with a lot of these projects and moving the field forward. Okay. Mm-hmm. Oh yeah, sure. I'll leave it there.
Okay. All right. Thank you. Okay, questions now. Let's start here and we'll go over there. And yes, sir.
Doctor, what is the raw cost of this genetic testing? say I wanted to just pay for it out of pocket, is that possible, and what does that cost?
You can pay for it out of pocket. I believe it's typically. Certainly. So the question was, what is the raw cost of the genetic testing? And generally, it's about $2,000 to $3,000 per test if it's not covered at all by insurance. But most insurances will actually cover the test. And a lot of these companies actually have patient assistance program where if they don't cover the test, you can apply into the patient assistance program, get it, subsidized. Yeah.
Okay, question?
What do you actually consider metastatic? If you have, if it's come out of the prostate and it's in the prostate area, but not in a distant location, is that still considered metastatic?
So the question was, what do you actually consider metastatic prostate cancer? And probably for our purposes, metastatic is any prostate cancer that's gotten out of the prostate into other parts of the body, whether that be the pelvic lymph nodes, or whether that be bones, or whether that be lymph nodes, not in the pelvis, but maybe they're higher up lymph nodes or organs. So anything outside the prostate is probably the cleanest definition.
May I add a clarification, because I'm not metastatic, but it's in my bladder, my rectum and so forth, but that's not considered by insurance and FDA as metastatic.
Why not?
It has to be remote. So that's why I never qualified, I still don't.
Yeah.
This is the hang up here. Okay, question back there? I get this.
I just have a question. If you have had experience with your patients who have been diagnosed with metastatic prostate cancer and who have gone through those initial Zytiga, Xtandi, blah, 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 onto chemotherapy, if they've had issues with their bladder after having Taxotere and dexamethasone, my husband just finished his 3rd dose and he's just having some crazy bladder stuff. So I'm just wondering if anyone else has had that experience, or if your patients.
Yeah, so the question was in the context of using docetaxel or Taxotere for metastatic prostate cancer, can there be issues in the bladder when it's used in with concurrent dexamethasone? So docetaxel does not directly negatively impact the bladder itself, but when people are on chemotherapy, they are immunocompromised, and it can potentially result in infections being more prevalent, UTIs being more prevalent. If somebody has already irritation of the bladder, but their blood counts aren't very good, they could potentially be at increased risk of bleeding from the lining of the bladder because chemotherapy has affected their blood counts, and now, they may be at increased risk of bleeding. So it's not necessarily a direct toxic effect from, there are certain chemotherapies that actually cause a inflammation of the bladder. They're known to do that. This is not one of them, but there can be secondary causes because of secondary symptoms due to indirect causes from the chemo, like putting people at risk of infection or low blood counts. Yeah.
I'm metastatic bone, but the genetic testing they have submitted for me was based on my biopsy of my prostate. Should I also have the bone mets sample? Are they the same or different or what?
So the question is a very good question. This gentleman has metastatic prostate cancer with bone metastases. He had his genetic testing done on his primary prostate from his biopsy and is asking, should I also have the genetic testing done on my bone? I would probably say yes. And the reason why that is because we have data from the Cancer Genome Atlas and of what the genomics are for people from the prostate itself compared to what the genomics are of people with metastatic disease, and they're different. Now, that being said, there are issues with sampling of the bone. And in the context of a biopsy that's probably done as just routine standard of care, I suspect that it won't be processed in the right way to allow for the genetic testing to be done. It has to be processed in a certain kind of way for the genetic testing to ultimately be done on it. And it's because the bone is hard. And for the pathologist to work with the bone, they put the bone in acid. And when they put the bone in acid, it kills the DNA. So you can't sequence it. So most of the time when we're just ordering clinical biopsies just for, standard of care purposes, that's what they do on the pathology side. We do things very differently on the research side of things, where we don't stick the bone in acid and basically have to handle very tough bone and cut it, and there's people that are experienced to be able to do that. But most centers don't really have the capacity, and honestly, our anatomical pathology, just routine pathology at UCSD, doesn't have the capacity to do that. It's only done in the context of research. So while I would say yes, we should get that bone biopsy sampled, it has to be done in the right way, because what you don't want to do is get a biopsy done, send it off to be sequenced, and then they say specimens can't be handled, or the specimen's insufficient to actually result in a test, That
type of bone,
Yeah, we could do it in the context of, we can certainly do that. So we would get you set up for, a biopsy of the bone, but then we'd also have our clinical research team there, and they take a core away so that it wouldn't go to pathology, and then we can potentially work with that specimen to do the genetic testing on it. Yeah.
Okay, in the back, we're in the back.
What would be causes for a change in your gene mutation? If you had no mutation issues now, is there likelihood with cancer you'd have mutations in the future?
So the question is, what is the cause for gene mutations in your cancer? And there's a lot of things that can cause the cancer cells to change. I mean, by definition, that's, cancer that's in the prostate is genetically a little bit different than cancer that has spread to the bone versus cancer that's been exposed to different therapies and then has become resistant to that therapy. So there's different selective pressures on that cancer, whether it be what kind of therapies you're receiving, environmental factors, factors within the body itself. The cancer itself can mutate, and so it can mutate over time. And so when we look at sort of the landscape of prostate cancer, we know that the genetics of prostate cancer, when it starts out in the prostate, like just by sequencing the prostate, is different than the genetics of a tumor that's in the liver. Like they're genetically different. They've kind of evolved over time. I like to think of it as almost like a gumball machine, okay? And in your gumball machine, you've got like all different colors in the gumball machine. There's like white gumballs and red gumballs and blue gumballs and green gumballs. And maybe you're exposed to a certain therapy and it kills off all of the green gumballs and all of the white gumballs. But the blue gumballs were really resistant to that therapy. And so they kind of hung around and they're kind of lying dormant. And then as the cancer changes, those blue gumballs start to take up the majority of what that cancer is. So, prostate cancer is very different. Each of the different cells in a prostate cancer, I actually had this in my talk, but I pulled it out. There can be different focuses. It can be different. We've done studies where we've exposed patients to upfront hormonal therapy and then taken out their prostate. And in the prostate, you can see different, in the residual, tumors, you can see different foci of tumor in there. And each of the foci has a different genetic makeup.
What about diet?
Huh?
What about diet? How does that affect?
So diet is huge, and I think it's important to obviously have a very well-balanced diet, because I think that's something that you as a patient can control, making sure your diet's rich in omega-3s, making sure your diet's rich in, calcium, vitamin D, which can negatively impact, when people are on hormonal therapy, they can have a negative impact of the hormonal therapy in the bone, so making sure you get enough calcium, vitamin D. There's been a lot of studies about the effect of pomegranate juice extract in prostate cancer. We're actually going to be running a study jointly with Johns Hopkins of a nutraceutical called muscadine for people with locally recurrent or biochemically recurrent prostate cancer. It's a almost like a supplement from grapeseed extract. So there's a lot. I think the key about diet is balance. I don't think that being sort of an extremist on one way or the other is, something that's going to be a positive thing for the cancer, So, making sure limit red meat is another big thing for prostate cancer. I would recommend if you go on the Prostate Cancer Foundation website, they have a patient guide, and you can download the guide, and there's an entire section on diet, nutrition, supplements. The thing that I tell patients about supplements is, if you're interested in doing, turmeric or ginger or whatever it is that supplement that you're interested in potentially pursuing, don't get it in a pill form. Go to go to Whole Foods and get a ginger root and put that in your tea. Don't go get a pill that says I'm ginger, or if somebody's telling you, for example, the turmeric, same thing. Just go get the spice. Don't get a pill that may have stuff in there that you don't know what it is, So I think in men who have prostate cancer, protein I'm sorry, the second follow-up question was, what about protein? For men who have prostate cancer, who are on hormonal therapy, who are at risk of muscle loss, eating protein is going to be key. And so if you do have a, vegan diet, or if you have a diet where you're really cutting out animal meats, you've really got to work hard to get that protein in so you can have the building blocks to make muscle. So, I think limiting red meat, but fish, chicken is good.
Okay, we got a question back there. Yes, you.
What discipline of medical professional would be best to deal with necrotic tissue inside of the prostate?
The question was, what medical specialist would best be able to deal with necrotic tissue in the prostate? Can I ask, in what context?
Well, I had biopsies done. They came out clean regarding cancer, but the doctor did tell me that I got necrotic tissue in the prostate. And to come back in a year. So I don't want to wait a year. I want to.
Yeah. So it would
Who
be.
do I need to talk to?
Probably a urologist. So that would be the medical specialty that would likely handle that scenario. Yeah. Mm-hmm.
Question here.
So, if you don't have a prostate anymore, but you still have a PSA, it's not necessarily a metastasis.
So the question is, if you don't have a prostate anymore, but you still have a PSA, it's not necessarily a metastasis. That's correct. So, so you can think of it as, for us to, prostate cancer is one of those diseases that we actually have the beauty of having PSA. For how much we love and hate PSA, we have PSA. It's a biomarker that shows us that the cancer is there. The PSA itself, there's really no other cells in the body that make PSA, and it's very, very specific to prostate. Whether it's normal or not normal, it's specific to prostate. In somebody who doesn't have a prostate intact, it's been removed, and their PSA is rising, that denotes for us that there is prostate cancer cells in their body somewhere. They're and so that usually will trigger some kind of imaging test. And I know that Dr. Siebert was here, I don't know if it was last month or the month before, talking about different kinds of imaging tests. But sometimes that PSA level, it's not high enough to actually show something on a scan. The scans are not sensitive. For us to see a nodule on a scan, you almost need like 1 million cells all together to show like here's a spot. But maybe there's just microscopic cells that we physically can't see. So there's this entity in prostate cancer, and it's probably different than other cancers, termed biochemically recurrent. And it's very much a confusing state for patients because it's not metastatic disease, but it's not in the prostate. So it's like, where is it? I don't understand. And it's likely microscopic. We can't detect it on imaging. We don't know how many cells it is, but it's not enough to cause 1 million cells to kind of come together and make a nodule, but it's there. And so yes, people can have biochemically recurrent disease that's not metastatic.
Thank you, and I love your gumball analogy.
Yeah.
Now, did you have surgery?
Oh, yeah, not as long ago as you were
About a
told.
third of our members have had surgery that didn't fit the prostate, the cancer.
Got it. Yeah.
And so what's their option? To go see you or,
Yeah.
normally it's radiation.
Yeah. I think for a lot of times, if you have prostate cancer that's recurred after surgery, you should see a medical oncologist, because usually if it's radiation, there's a discussion to be had about should it be given with hormones or not. And if you've had radiation or decided you don't want to do radiation and you're just dealing with a PSA rise, then it's thinking about, well, what are the right strategies for me? Am I well enough that I can consider doing something like, a clinical trial of muscadine, that's a nutraceutical, or do I just start regular old hormone therapy, or am I high risk that I need more than just the hormone therapy? Do I need something else? There are other studies that are looking at more stronger hormonal therapies like the Erleada and the Zytiga together with Lupron for people who are higher risk. So having that discussion and knowing what your options are is important.
Let me just tell you, prostate cancer is the only cancer where the first person you see is a surgeon. Every other cancer you see an oncologist. But because you need a biopsy, you got a high PSI, let's get a biopsy. So he sends you to a urologist who's a surgeon. And so you're kind of over in that path of that. You don't go automatically to see an oncologist.
That's
so
correct.
I just wanted to promote your profession.
Oh, thank you.
You're specialized in prostate oncology,
Right.
And we have others. Go see a prostate oncologist before you go necessarily into surgery. That's just a plug for how important that is. Okay, let me finish down here.
When is it practical to do blood-based genomic testing versus tissue sample, and what's the difference in the quality of results?
Yeah, that's a very good question. So the question is, when should you consider doing blood-based genomic testing? So blood-based genomic testing, or classically termed as a liquid biopsy, is done from circulating free DNA that's in the bloodstream. The source of that circulating free DNA that is in the bloodstream may be presumably tumor, but could be from normal cells too. So there's different platforms out in the community. And for example, I'll mention Guardant, because Guardant has a panel. Foundation Medicine has a panel. And the panels are usually smaller. So instead of doing 300 to 500 genes, they're really only doing anywhere from 20 to 60 genes. So it's not as all-encompassing. And they're not prostate cancer specific. They're kind of just general tumor specific. There is no prostate cancer specific cell-free DNA assay. Okay. And there's been some studies, we don't 100% know. There's a lot of ambiguity around whether what's in the blood directly correlates with what's in the tissue. And there was actually this nice editorial and publication by the Johns Hopkins group by Dr. Pienta of patients undergoing different kind of panel tests, different kind of cell-free DNA tests, and each one spit out different results because they have different platforms, and it's the same patient, within a 1-month period, they underwent the same test or different tests, and every one of them kind of was a little bit different. So I think it's helpful, but I think you need to be cautious with interpreting the results because of the problems with the test itself. And I always say if you can get tissue, it's better to get tissue, but we may not be able to get tissue in all situations. And the other thing is, sometimes you may just not even be at the detection level that you would actually have cell-free DNA to actually sequence. So the test may come back negative, but it's not actually negative. Or negative meaning it may say you don't have any mutations, but you have to interpret that by, is it truly that you don't have any mutations, or they just didn't actually find the cell-free DNA to have any mutations. Like, was it a non-diagnostic test or was it a negative test? You won't actually get that data from these tests. They'll just say no mutations, and then you sort of have to think, well, maybe I wasn't suitable for this test because my PSA was so low, and the likelihood that I was going to have circulating free DNA was actually low anyway. So I'm not really negative, I'm just non-diagnostic. And there's a difference there, right?
Yeah. Okay, question in the back there. You already had one, but it didn't say
I'm not.
Okay, I'm
I
sorry.
have a question. The question is about the role radiation plays in men like me who was diagnosed with metastatic disease right off the bat. I had my spine irradiated because there was a tumor there. Lupron failed after 6 months, and I've been on Zytiga for 6 months, and it's working. But now the issue arises, should I have my still existent prostate, lymph nodes, and prostate fed in the hopes of disturbing its ability to metastasize and reducing the amount of dormant cells? Is that something that you
Yeah. So the question is, what is the role of prostate and pelvic radiation in the context of metastatic prostate cancer that's become resistant to hormonal therapy for somebody on Zytiga? And the question to that is, the answer to that is there are no prospective clinical trials to guide decision making. So I can't say, oh yeah, we've got a trial for that, we did that, and this is what the numbers are. That being said, I think it is something that we generally, when people enter into that hormone resistant phase, sometimes we kind of step back and think about, well, what is the intent of the local radiation? If somebody has a big bulky tumor and we just need to control it because we don't want there to be problems, with regards to it invading the bladder or it invading the rectum, then there absolutely is a role for pelvic radiation, more so to control symptoms. But even in somebody who may have a small prostate where it's not a locally advanced problem in addition to it spreading, the role of radiation probably is a little bit more ambiguous. So, and I think a lot of it is, patient-physician factors. Are you going to be in the category of, I'm going to throw the kitchen sink at you, even if there's a hint of data that's going to say that it's going to be positive, go ahead, do it anyway? Are you in the mindset of, no, unless there's evidence that it's going to work, I don't want it, or you know what, I don't want to deal with the side effects of that, I don't want it. So this is sort of the art of medicine, where the data may say what it is, it may be what it is, but you end up kind of veering around that because it's not so black and white, and there's a lot of gray. Yeah.
Yes. I'm currently on Lupron and Zytiga, and I have about a centimeter of cancer. We did a acetate test and found it in the left lymph node. Okay, so the plan is to radiate that whole area. Okay, would it be better to have the genetic tests on that before they radiated? And is it going to be effective because I'm on Lupron and Zytiga right now?
Right. So the question was, this gentleman has lymph node positive prostate cancer in his pelvis. He's on Lupron, on Zytiga, and the plan is likely to move forward with radiation, but the question is about biopsy, should we sample that lymph node? There's a lot to think about there. So one is, where is the lymph node? Is it readily accessible? Can we safely biopsy it? If it is readily available, how long have you been on the hormone therapy? Did you just start on the hormone therapy, or have you been on it and your PSA is undetectable, that the likelihood of finding active cancer there is low? So all of these things kind of need to be considered before doing the biopsy. Okay. Yeah.
All right, you start.
This is a simple question, but we've talked about different doctors and stuff like that. As an oncologist, do you coordinate therapies, or do you do radiation? What is exactly as an oncologist versus the other thing?
So the question was, what exactly is a medical oncologist versus other specialties? And I do think that a lot of times medical oncology actually does end up coordinating the care for most men who have prostate cancer, especially cancer that's higher risk or more advanced, because it's just there's a lot of moving parts. You know, our surgical team, you know, they are mainly doing the radical prostatectomies, you know, so they're providing that service, that skill. The radiation oncology team, they're doing pelvic radiation. And in some context, if something has shown up here or there in the bone or wherever, they may do spot radiation in those various areas. But in regards to actually coordinating the care and thinking about systemic therapies, and following, that's usually done with medical oncology, you know? So, you know, so I just put that out there. You know, the surgeons, if you've got, you know, low risk or intermediate risk prostate cancer, you've undergone a radical prostatectomy and you're just being followed for your PSA, I think that's, you know, totally reasonable. You may not necessarily need to see a medical oncology. There isn't a need for any other intervention. But I think for people who have, you know, more aggressive disease, I think it's probably helpful.
I use the analogy of an oncologist like a travel agent. If you say, how do I get to San Francisco? A lot of questions, how long, fast, where, and so forth. You call Southwest Airlines and say, how do I get to San Francisco? Guess what? You're on the plane. Okay. Not that looking at why you want to go and where you want to stay. Okay, we got a question. Bill. Steve, sure.
Yeah, there was a recent article that came out from the Secretary Studies, Neuroendocrine, prostate cancer. They talked about how regular prostate cancer, after prolonged ADT, can convert into a standard cancer which doesn't have any treatment.
Yeah, so the question was, there was an article that was put out by the SVP about neuroendocrine prostate cancer coming on after exposure to androgen deprivation therapy. And yes, it is an entity that we are now seeing in, I think we're seeing it more prevalent, of this treatment emergent neuroendocrine prostate cancer, which can be more resistant to hormonal therapy. Probably, you know, different groups have come up with different percentages, but I'd probably put it somewhere on the 10 to 15%. And it's of patients who have metastatic advanced disease, have been exposed to various prostate cancer therapies, and then this kind of entity transforms. I want to step back and say, this is not a reason to not treat your prostate cancer and not a reason to not go on hormonal therapy because you're worried about this entity you know, coming on. You know, it's because then you're going to be in a worse off situation. So there are many studies that are kind of right now evaluating what are the molecular genomics of neuroendocrine differentiated prostate cancer, and we're not there yet. It could potentially be more responsive to actually immunotherapy in addition to chemotherapy. So there are studies that are being done specifically looking at the role of immunotherapy for people with neuroendocrine differentiated prostate cancer. We had a study at UCSD that is doing just that, looking at Keytruda with Yervoy. I should say actually Opdivo with Yervoy. So Nivo-Ipi, nivolumab and ipilimumab for people with treatment emergent neuroendocrine prostate cancer. Actually, the cohort just closed and we just reached out to BMS to add another 20 patients. So hopefully they'll allow us to be able to do that. But I think if you have that entity, it definitely warrants being seen at an academic tertiary care center so you can understand what cutting edge, you know, systemic treatments you have at your disposal.
Questions over there? Sir, you asked about genetic testing. Have you got any questions for our speaker?
She's doing a good job of answering.
Okay, thank you. All right, let's go back over here. All right, down here.
If you have a PSA that's under control or decrease with hormonal therapy or immunotherapy, is there still a risk of metastatic disease from prostate cancer that doesn't necessarily express PSA?
The question was, if you have a PSA that's declining on hormonal therapy, is there a risk of a prostate cancer that may be growing that just doesn't express PSA? Yes and no. Okay, so it's all about the clinical context. What context are we in? Okay, do we have somebody who we know has known metastatic disease and known, like, they're a Gleason 5 prostate cancer. When they were diagnosed, their PSA was only 9 and they had Gleason 5 + 5 = 10 prostate cancer, and it was widespread, and they started out with a low PSA to begin with, or is it somebody who basically had a PSA, had their prostate removed, PSA went down, and then slowly rising, and now they're on intermittent hormonal therapy. So it all depends about context. In the former, yes, I'd be worried. In the latter, I'm not really worried. Okay.
You really had a question in the back there.
Yes, just going back to diet real quick. Is sugar feed better life?
So the question was, does sugar feed cancer cells?
Does cancer cells feed on?
The question is, do cancer cells feed on sugar, yes or no? Every single cell in your body needs sugar to survive, okay? Your brain, like on a glucose FDG like PET, lights up bright, because your brain needs lots of sugar. So if you don't get sugar, if you don't get glucose, your body is smart. It will break down your muscle and make glucose from your muscle, okay? So these diets that are like absolutely zero glucose, I think you need to be careful about them. Limiting refined sugars, white breads, sweets, things like that, but diets, there are not of great natural sugar sources, like from fruit or agave, honey. You don't need to eat a diet that is 100% devoid of sugar, because your body will figure out how to make glucose, and it will be at the detriment of your muscles and other parts of your body. Yeah.
Okay. Could you compare treatment strategies of just, say, slowing it down with ADT versus a hit it hard strategy like the androgen annihilation clinical trial? Maybe tell us more about that androgen annihilation clinical trial.
Yeah. So the question was talking about different strategies of androgen deprivation therapy, whether it just Lupron versus more stronger hormonal therapy. So at UCSD, we have a clinical trial that's open. It's a national trial that's being run through the Alliance, which is one of the large cooperative groups through the NCI. It's a trial that's designed for people who have a rapidly rising PSA, but they don't have evidence of metastatic disease on standard imaging. The trial will allow patients to go on if they have metastatic disease that was detected on PET imaging or research imaging, but not just routine CT bone scan. The trial is designed for patients who have not had extensive prior hormonal therapy. So hormonal therapy that was given in the context of, radiation, whether it be for 18 months when somebody was recently diagnosed, or maybe 6 months in the context of radiation for recurrent disease, they would be allowed, but it's not for people who have been on and off hormonal therapy, okay? The trial is designed because we're learning that in people with metastatic disease, treating patients earlier on with Zytiga actually improves their outcomes. Treating patients earlier on with a drug called Xtandi, which is like apalutamide or Erleada, actually improves their outcomes. And so the trial is set up to answer the question of, does actually giving somebody stronger hormonal therapy matter with regards to their time to developing metastases or their recurrence? So it's a randomized trial where patients get randomized to one of 3 arms. They either get degarelix alone, which is it's akin to, it's a GnRH antagonist that basically just drops down your testosterone. Do they get that drug plus Erleada or apalutamide which is a drug that blocks testosterone binding to its receptor, or do they get those two drugs plus Zytiga, which is a drug that prevents the production of testosterone in the adrenal glands, the testicles, and the prostate cancer cells themselves. So it's, the reason why I like this trial is it gives you the standard of care plus. There's no placebo. It's not blinded. You know what you get. We know what you get, but you're randomized. So you either get the standard of care, or you get the standard of care plus 2 drugs, or the standard of care plus 3 drugs. So you have 2/3 chance of getting something extra in addition to the standard of care. Okay, and then you get therapy for 1 year, and then we stop the therapy and watch the PSA and continue to follow you. And after you come off the trial, you're just in follow up. If the PSA were to go back up, you're not wed to going back. I mean, it's sort of at the discretion of your provider what they would do next. So yeah.
You had a question. Go ahead.
Yeah, I did have one question in regards to bone health while I'm getting treatment between Xgeva and Zometa. Could you comment there? I've had sort of 2 opinions. One, yep. I've been on Xgeva for about a year. One of my doctors says, my guy's on for 5 years. The other one, I like to go over to Zometa. I'm not sure sort of what the pros and cons are.
Yeah. So the question was to talk a little bit about bone health and prostate cancer and the differences between Denosumab or Xgeva and zoledronic acid or Zometa. Okay. It all depends the context that you're receiving the drugs in. So I would like to break that question up into people who have hormone-resistant prostate cancer and they're getting these drugs versus people who have hormone-sensitive prostate cancer and they may be getting these drugs. So in the context of hormone resistance, the use of these drugs is really to prevent skeletal-related events. And skeletal-related events are defined as fracture to the bone, needing surgery to the bone, needing somebody having cord compression where the tumor actually pinches off at the spinal cord, needing radiation. So it's these kind of acute kind of events. So the purpose is more so to prevent these events from coming on. Now, the 2 drugs that have been approved in that setting are Denosumab. It's given as a subcutaneous injection once every 4 weeks. There are studies that are looking at more longer, testing whether giving it once every 4 versus once every 12 weeks is just as efficacious. The major side effects with that drug are it can drop your calcium levels and cause osteonecrosis of the jaw, and probably do it at a higher likelihood than Denosumab or than Zometa. But it probably also works a little bit better than Zometa. Okay. Now, Zometa is given as an intravenous infusion, and we typically over about 15 minutes. And it is now given, it used to be given on a 4-week schedule, but studies have shown that giving it every 4 weeks versus every 12 is no different. So give it every 12, why give it every 4? So we tend to give it every 12 weeks. The major side effects with it are sometimes it can cause an infusion reaction within the first 24 hours. That generally is just mitigated with just some Tylenol or ibuprofen. But it can also cause low calcium, and it can cause this osteonecrosis of the jaw, rarely, but probably, rarely. And the other thing with that drug is you need to watch kidney function. So people whose kidneys aren't totally normal, you got to be careful about the dosing of it, okay? Now, I will say that these drugs, they were FDA approved at a time when we didn't have Zytiga. The only thing we had, Zometa was approved before we even had docetaxel. So they were approved a long time ago when we didn't have efficacious therapies to treat CRPC or castration-resistant prostate cancer. Denosumab was approved in 2010, again, before Zytiga, before any of these new drugs. And generally what I tell patients is actually the number one thing to prevent these skeletal-related events from coming on is treat the disease. So these drugs were actually approved when we couldn't treat the disease. We just didn't have good, and no drug company is going to redo the trial now because then it's going to be negative, So there's no incentive to actually repeat the studies in the current day and age. So, you may get some mixed messaging about that, that though the trial said do it like this, some providers may say, you know what, you don't need it every 4 weeks. Like you don't need it we can give it with your Lupron. And it's because of the fact that these studies were done moons ago, and trials of Zometa and Erlita, not Erlita, but trials of Zytiga and Xtandi have demonstrated that those agents in and of themselves can actually drop your SRE rate. So the other context is using it not for castration-resistant disease, but actually using these drugs to protect the bone when people are on hormone therapy. So hormone therapy can cause bone loss. Your bones, they can either look like a thick Persian rug, or they can look like a piece of gauze. And if they look like a piece of gauze, these drugs can help them look more like a thick Persian rug. And that's when we do a DEXA scan to see if the bones are nice and strong or not. If they're weak and you're on hormone therapy and they're at risk of getting weaker, you can use these drugs to help strengthen the bones. So 2 different scenarios of how these drugs are used in prostate cancer.
You have a question there.
Yeah, you mentioned that in patients with metastatic disease, there can be genetic differences from one site to another.
Mm-hmm.
The bone, the tumor that's in the bone is different from the tumor that's in the prostate
Yeah.
or different things. Is that necessarily the case, or in some patients are the tumor cells identical, and in other patients they're different? And the reason for that question is because if it's uniformly so that the cells are genetically different, that would mean you have to work with the bone, with the mets that are in the bone, no matter how difficult it is to do. Does that make sense?
Right, it does make sense. The question is it absolutely the case that they're different, that the prostate cancer that's in the bone is absolutely going to be different than the prostate cancer that's in the prostate? And it's not 100%, but they are likely going to be genomically different entities. And so I think a lot of times we may start with the prostate tissue because that's what we have and that's what's readily available, and we sequence that. And if you're following somebody and you repeat scans and then a new spot were to pop up or a new lesion and you're looking and it could be safely sampled, it could be safely biopsied, it's always good to pause and say, do I need to resample? Is it going to affect my treatment decision at this moment? Or am I already planning on doing something else that information from that test is not going to help me? I will say with regards to the genetic testing that it does take time for the results to come back. So it can take anywhere from 4 to 6 weeks for the results to come back. So I always like to do it when I don't need it. Like tuck it in my back pocket, save it for later because a time will come when we may need it. And then we'll say, oh, well, we've done the genetic testing. This is what your cancer showed last time we did the testing. We really need to get something going now. We can do the biopsy, but let's get you going on this and wait for the biopsy results to come back. Because I don't want you waiting for 8 weeks for the biopsy results to come back. And you know what I mean? So
You mentioned a couple of times how difficult it is working with the bone mets. And if it's the case that a large percentage of the patients have different lesions in different sites, then your treatment is substandard if you don't.
not necessarily, because the number of people who have bone-only disease without lymph node, without any other, you got to look at the whole scan, itself. Like, is there a bone spot that has a soft tissue component? You can sample the soft tissue. Is there a lymph node that you can sample? So I think it needs to you got to look at the whole picture.
The related question is, are they necessarily the same at the same site? In other words, are all bone mets the same in the hip or in the pelvis?
So the question was, within the bone, are all the bone mets within the bone different or the same? And we don't know the answer. And honestly, practically, we're not going to subject patients to sampling of every single site. So generally what the strategy is in the metastatic setting when people do have metastases, if you're scanning and one site is stable but the other site is progressing, biopsy the progressing site. What's different about the progressing site that it's growing and the other stuff is stable?
Thank you.
Okay, I have a call on nature, but okay. Chuck, you have a question, and the gentleman behind you, and I'll be back.
So my question is, do you have a trial for prostate cancer, metastatic, resistant, using PARP inhibitors?
So the question is, do we have a clinical trial of metastatic prostate cancer that's castration resistant using a PARP inhibitor? Yes, we do. We have a trial of radium-223, which is a liquid radiopharmaceutical. It was actually the first, it's an FDA-approved agent for prostate cancer. Yeah, Xofigo, and it's paired with olaparib, which is a PARP inhibitor. So it's designed mainly for people who have low volume lymph nodes and bone metastases, but that is open. Yeah.
And if you've already had Xofigo,
If you've had Xofigo, you wouldn't be a candidate for it. But if if you had Xofigo, you wouldn't be a candidate for it. Yeah.
thank you.
Mm-hmm.
So my question is way general compared to what has been going on here. In terms of diagnostics, before I had prostate cancer, I did not even know what 3T multiparametric MRI was.
Yeah.
And now I'm wondering, as far as terms of diagnostics, how important is genomic relative to MRIs and X-rays?
Yeah.
Biopsies?
So the genomics, the question was, how important are genomic tests with regards to diagnostic, diagnostic imaging tests? And I think they're two different things. So the genomics, the imaging tests are really trying to refine how we detect prostate cancer and defining anatomically, like, can we better detect prostate cancer? The genomic testing is trying to understand how can we better treat prostate cancer. So one is sort of, the genomic test is not a diagnostic test. It's not used to detect prostate cancer. It's used to understand what is the genetic makeup of the disease and how can I treat it, as opposed to, can I find it? Okay? So that's sort of the difference between the two. Okay? Yeah. Sure, here we go. Yeah. So the question was, can we talk a little bit more about muscadine? So muscadine is a nutraceutical, which means it's kind of a natural substance. It is being tested in clinical trials for men with biochemically recurrent prostate cancer that has not spread, okay? So in this entity where people are doing a lot of hemming and hawing of, should I go on Lupron? Can I drag my feet? Should I start now? Should I start later? So this is a trial of a nutraceutical agent or a supplement almost that is being tested. Now, we don't know if it works or it doesn't. That's why the trial is being done. But the substance is basically developed, or the muscadine is developed from grapeseed extract, and it affects the oxidation or the oxygen kind of levels within the cell. And so I'm not saying go out there and take muscadine, because we don't know if it actually works at the end of the day. The trial is being done, but it's like I said, it's being tested. Okay, so we hope to activate the muscadine trial in the next couple of months at UCSD, and that will be available for people with biochemically recurrent disease. And like I said, that's the trial that we're running with our colleagues through the Prostate Cancer Clinical Trials Consortium and Johns Hopkins.
What about revenge or other fields?
Just a minute. 2 more questions, then we're going to have to cut it off. And if she wants to stay a while, she'll handle some individual questions, but we're nearing the time, okay? 2 more questions.
Revenge or immunotherapy for early for cancers that
So the question was, what about Provenge or immunotherapy for prostate cancers that are still in the prostate? A very timely question, because one of my colleagues and friend, Dr. Kelly Parsons, he's actually coordinating a study at UCSD now of Provenge being used in an active surveillance patient population to prevent prostate cancer from progressing into a more aggressive form of prostate cancer. So it is being tested in the localized setting, but only in the context of clinical trials. Yeah.
I recently went through a course of radiation for my first metastasis. Was able to show on the scan. When the radiation oncologist was listening, it may be okay for me to hold off on
below 0.1 and stays that way for some time. But I'm gathering that there are other oncologists who say that this automatically be an ADT.
Yeah. So I think, the question is, this gentleman received radiation to a metastatic focus that was detected on imaging, but hasn't yet started ADT, and is getting kind of some mixed messaging about whether should I start on ADT or should I not start on ADT. So I'm going to take that back as in the current era of more novel imaging modalities and more sensitive imaging tests, this entity of oligometastatic prostate cancer is evolving or developing, where people are being diagnosed with prostate cancer much earlier on, where maybe they have 1 or 2 metastatic spots, and thinking about what's the best way to manage those patients. Because historically, people who had metastatic disease, you just say, okay, no local treatment, you're just going on your ADT. But we're thinking that actually this entity, maybe it's going to behave a little bit differently. Maybe we can adequately treat people with just focal therapies, defer ADT. Or maybe with the combination of focal therapy and ADT, they do better than if they just get ADT alone. So we don't know the answer to that question. We don't, and it's the reason why there's probably a lot of hemming and hawing is because we don't have prospective data to say, do that or do this. The trials are currently being done and currently being conducted to say, well, what is the value of spot radiation in the context of metastatic disease? What is the value of doing the combo versus not? We don't know. But I think this is where the art of medicine comes into play, that if you have a patient, you're thinking about the side effects of therapy, you're thinking about, going on hormones, not going on hormones. If we can bypass the time of needing to start hormones, give radiate, and then see what the PSA does after you radiate. If there's a response, maybe we can drag our feet regarding starting the hormone therapy, because you're never going to read a book that's going to tell you at this time start ADT. It's likely that you're going to need to start ADT at some point in time, but we don't know when. And if we can drag our feet, maybe that'll be better for you quality of life wise. So there isn't a right answer. I think but it's a lot of discussion with your team and, kind of discussion with yourself too, of like, well, what do I want to do? How aggressive do I want to be? Okay. Yeah.
Okay, we have a short video.
Okay, great.
I'd like to show that, and then you can close for us, okay?
Talking to many, many men that prostate cancer is a really difficult disease, and men, particularly who have advanced disease, suffer lots and lots of aspects of that really hit at the heart of them being men.
It's a catastrophic bit of news at the beginning.
Whether you use the word advanced, metastatic, stage 4, it's devastating.
It's very hard for men going through this journey, which can last a long time, and each treatment that we administer to patients has its set of side effects.
If you have advanced disease like metastatic disease, that's a lethal disease. We need better treatments, better quality of life. So it's two different things. We need improvement for both.
This is a disease that plagues all men around the world. And if we can understand that better, to try to help them better, to help their families deal with this better, that's an unbelievable opportunity. First of all, it's never really been done before. This is collaboration on a worldwide scale. You're trying to get whole countries to ask the same question in the same way. These are countries that speak different languages, have different cultures, have different healthcare systems, have different access to new medications. That's why it's unprecedented, because a global movement like this is virtually impossible to pull off, and yet Ironman is doing it.
It's really putting together a community, a culture of physicians and patients looking and learning together about this whole experiences, not just from their own vantage point, but those of hopefully hundreds or maybe thousands of others.
it would be impossible to do a randomized trial for all of the different combinations of therapies that men have. So really a registry is our best option for being able to study this.
So first of all, you will see, is there differences between countries, let's say between Europe, US, or Australia, US? And especially from a patient perspective, I find it really interesting that you're gonna find out, if you have the data, what kinds of sequences are best. Perhaps you even find predictive markers in the blood samples that could tell you which patients profit most from which treatment.
To do that in a scope that we're doing it is something that's never been done before.
We really firmly believe that bringing together clinical research with the experience of men and the outcomes that they report from those treatments, we can come up with something that really can truly transform the experience of many men in the future.
You want to comment? We got one more question. All right. I want to thank you for coming.
Of course, thank you.
Enjoyed it.
Thank you. Thank you.